Welcome to 2-minute anaesthesia in critical care. Today let's discuss the single cardiac ventricle. A single ventricle or univentricle heart describes various cardiac structural abnormalities in which one ventricle is severely underdeveloped or a ventricular septal wall has not formed, thus leading to a single ventricle. Examples of conditions which can lead to this include the hypoplastic left heart syndrome, tricuspid atresia, and the double outlet right or left ventricle. It's a rare condition affecting 2 per 100,000 pregnancies, and the most common form is the hypoplastic left heart syndrome. It's diagnosed commonly prenatally by routine ultrasound assessment. However, postnatally, patients can come in with symptoms of heart failure and thus require echocardiography plus or minus other imaging, including CT or MR. Broadly speaking, the challenges of managing a single ventricle include identifying all cardiac lesions, as there may be other lesions involved, maintaining a balanced circulation, so ensuring the flow to the pulmonary circulation is equal to that of the systemic circulation, and this may be based on targets set based on the individual patient and thus their underlying pathology, and therefore the management options, which is based specifically for the patient. Management. Immediate management may involve the use of prostaglandins, which may be continued for up to 14 days based on the etiology, in addition to airway and breathing support from high-flow nasal cannulation all the way to intubation, cardiovascular support and diuresis. And finally, surgical management. This will be discussed on the next slide. Broadly speaking, the surgical options are split into two groups: palliation or transplantation. Palliation is also commonly referred to as incomplete repair. There's 3 stages: stage 1, 2 and 3. Stage 1 is based on the underlying etiology and may involve a PA band, so a band around the pulmonary artery to reduce flow to the lungs, a BT shunt, or the Norwood procedure, commonly performed in less than 7 days. Stage 2 is the Glenn, performed during 4 to 6 months. Stage 3 is the Fontan, 2 to 4 years. Transplantation is commonly referred to as stage 4. Now let's discuss the Norwood procedure. Developed by William Norwood, which aims to protect and provide stable pulmonary blood flow to prevent overcirculation and protect pulmonary vessels. It's composed of 4 components: the atrial septectomy, the closing of the PTA, aortic reconstruction, and a shunt, which could be BT or a SANO. Stage 2 is the Glenn procedure, developed by William Glenn, the goal of which is to redirect blood flow from the upper body to the lungs. This is performed before the Fontan, which is a stage 3 procedure, as the blood flow in the upper body is greater than that in the lower body, until development occurs. It involves removing of the systemic portal shunts performed in stage 1, and then a SVC to right pulmonary artery anastomosis. And finally, stage 3, the Fontan, developed by Francis Fontan in 1968. This part of the operation directs systemic venous return into the pulmonary circulation, thus achieving passive filling of the pulmonary circulation without the need of the ventricular propulsion. This is achieved by an anastomosis between the IVC and the right pulmonary artery. In the event PVRs increase, pulmonary vascular resistance increases, there's a shunt into the right atrium. This ensures adequate cardiac output. The pressure in the venous system must be greater than that of the right atrium to achieve flow from the IVC into the right atrium. And finally, the prognosis: 80 to 90% survival at 30 years. Once again, thank you for watching.